Hello, everyone, and welcome to Occupational Therapy 236, OT with Youth. My name is Melisa Kaye, and I'll be your instructor. Today's topic is about mental health treatment settings and continuum of care for youth. It's also our last lecture for this semester, so congratulations, you're in the home stretch. Let's go ahead and get started. We have 3 objectives for today. We will identify the continuum of care for individuals with mental illness. We will also be describing the various practice settings where services are provided. And finally, we're going to identify the types of OT services that are typically provided in each of those care settings. We're going to start with the acute care setting, and this is acute inpatient. First, an overview of how this looks and what it might be like. The purpose of the acute in-care setting is to evaluate, diagnose, and stabilize acute symptoms. So this might be someone that is having an acute schizophrenic episode or an acute manic episode, has extreme depression, often with suicidality, or is having a severe problem with drug and alcohol. The length of stay, which is abbreviated LOS, is 3 to 7 days up to about 2 weeks, so it's pretty short term. On the team would be a psychiatrist for medication management, a psychologist for more generalized mental health issues, a social worker to coordinate services and help get resources, a nurse for ongoing medical needs, and an OT. When we're in this setting, we look for severe exacerbation of symptoms. So the person is really in the midst of a set of florid symptoms, and the setting is 24 hours a day, 7 days a week, and it is a locked unit. So that's kind of what that setting looks like. There's a number of terms associated with an acute inpatient setting. The first is something called a 5150, which is shorthand and a code for involuntary detention. And it is involuntary detention of mentally disordered persons for evaluation of treatment. It's a legal procedure, and it's for 72 hours, so 3 days. And there are certain criteria that one must meet in order to be held under a 5150. So they are a danger to themselves, they're threatening self-harm, a danger to others, so they're threatening others, or something called gravely disabled, which means that the individual is unable to provide for his or her very basic personal needs for food, shelter, or clothing. The evaluation and treatment consist of a multidisciplinary analysis of this individual. After this initial period of 72 hours, there's a few things that could happen. Either the individual will be released, or they will sign themselves in voluntarily into the setting, or, if they're still acute, they will go on a 14-day involuntary hold, and this number is called a 5250. So we start with a 5150, we move to a 5250. And to qualify for a 5250, they still need to either be a danger to themselves or others or gravely disabled. And in that interim period, right, the 3 days to 2 weeks, what we're looking for is some stabilization of that individual. All right, so now we're up to 2 weeks, yeah? So there's a number of things that could happen at that point. Either they're released, they sign in voluntarily, they're put on a 14-day involuntary hold, right? Well, that's the 5250. Or a 30-day involuntary hold, which is a 5352 if they're gravely disabled, again, which means that they're not able to provide for their basic needs. There may also, in very extreme circumstances, be an 180-day involuntary hold, which is called a 5300, and that's if the person is a danger to others. So they're homicidal and they are hell-bent on wreaking havoc and injuring others. Or the final thing that may happen is something called a permanent conservatorship. This is challenging to get, and it is when someone is deemed unable to care for themselves and unable to be on their own, and someone else, either someone in their family or a court-appointed person, is their conservator and makes decisions about their life, about their finances, etc. This is called a 5350. Now, every year, the 5350 or the conservatorship comes up for review so that we can get more accurate information about where the person is at. The role of OT in acute inpatient setting, and with every slide that has something about the role of OT, you will see this little symbol of the four colored hands, the blue, red, green, and yellow, which will just be a way of alerting you to the fact that this is what does OT do in this setting. So it's just a little visual symbol to alert you and signal you. All right, so role of OT. Well, certainly we're going to be doing assessment. We'll identify strengths and deficits of the client and also identify supports that the client has for discharge. So we're always looking for how would they fare in the larger community and what supports in terms of housing, caregiving, job supports, financial supports, etc. might they need. We're also going to be collaborating in this setting to provide information that's uniquely within the scope of OT practice about occupation to the rest of the team, and also to make recommendations to the team regarding the patient's function and their expected discharge environment. And this is going to aid with discharge planning. So we're very good at looking at the person holistically and figuring out where are they at now and how does that reflect on what they would need after they're out of the hospital. The assessment, the ACLS, is common, so the Allen Cognitive Levels, and it's an individual assessment with a group set observation, and then it's also short term, right? So the goal is to stabilize and transfer the person to a different level of care. So it's going to be kind of down and dirty and getting that person just more stable in their life. The role of OT intervention is a number of things, right? So we're going to work on reality orientation. So having that person actually in touch with what's going on with them, with the world, with their setting, etc. So remember, if someone is in a state of acute psychosis, they may not be in touch with reality. Likewise, if they may not be oriented to person, place, and environment, and time, So we're also going to focus on group treatment, and again, it's with an overarching goal for stabilization and discharge. We will help client organize their daily activities. That includes self-care, home management, leisure, and community and social participation. We may help them with stress management and developing coping skills to help them remain more stabilized. So self-regulatory skills will figure in here. We'll provide education regarding aspects of the illness so that the person is really aware of what the parameters of their illness are, what their symptomology is, and potentially what they need to do when they feel those symptoms coming on or being exacerbated. And finally, we will engage in psychoeducation. Again, likely in a group. It could be arts and crafts, could be goal setting, could be medication education, etc. Excuse me. So throughout this presentation, I will be noting different local facilities and resources and giving you examples of the different care locations and environments that represent these different levels of care. So Mills Peninsula Adult and Adolescent Inpatient Hospital, which is in San Mateo County and in San Mateo, so maybe half hour, 45 minutes from San Jose, is a place where there is an inpatient acute ward. There's also inpatient acute in San Francisco. Individuals would work on potentially movement groups, task groups, stress management, expressive arts, and dialectical behavioral therapy, or DBT. Check out the presenter notes throughout this presentation. There's some additional information. I think that you're familiar with most of this, so I'll give you a little bit of information, but then do download your slide deck and check the presenter's notes. So when we're thinking about Mills Peninsula, again, it is a locked ward. The person cannot leave the unit unless they're getting medical treatment or they're going with a group, even on weekends. So it's very controlled. The OT would lead about 3 groups a day. It might be movement, activity. We might split the activity group for higher and lower functioning clients. And everyone is invited to attend. However, many people decline, right? So they're in a very exacerbated state of their mental illness, and so it can be hard to engage in occupation and activity. There's morning rounds typically before the groups start, and that's where OT, along with an interdisciplinary team, would review new patients, review progress of patients that have been in the facility for a while, and raise any concerns that they might have. New patients would be individually assessed by OT, and this is more urgent and needs to be completed really close to the admission date so that we see what's going on with this person when they were 5150'd. Some patients aren't appropriate for individual interviews or assessment, and so we may do that differently, but typically we're going to look at that individual. Individual sessions, which also happen, are kind of on an as-needed basis, and the case manager will often request an individual session for a specific need. For example, applying for disability, completing a project, or further information on something that was addressed or raised in a group setting. Our next environment is a chronic inpatient setting. So our first environment was acute inpatient. This is chronic inpatient. This type of setting is indicated for folks with major mental illness and an inability to function in the community. Diagnoses include schizophrenia, Alzheimer's, other organic mental disorders, and conserved clients. So remember, right in the beginning, we talked about conservatorship, and folks who have been conserved may participate in chronic inpatient environment. The length of stay varies from months to 1 to 2 years. Examples include the dementia units at skilled nursing facilities and a location called Crestwood Behavioral Health. There are also partial hospitalization programs, which are known as PHPs. And I didn't give you much more information about the chronic inpatient because it's the same setup as an acute inpatient, where it's a locked ward. There's high levels of supervision. OT is there. We work on some of the same things, but more on a maintenance basis because these folks are not expected to change an awful lot over the time that they're there. They may, and we always want to have high hopes but reasonable expectations. So, moving on to partial hospitalization programs, or PHPs. It is an intensive short-term program But unlike the acute hospitalization, which is also short-term, this is a live at home, but then one goes to the program for about 6 hours a day, Monday through Friday. The purpose of these programs is to reduce the need for inpatient services, right? So it's a step down, but it's still intensive. And we want to keep folks in their typical and natural environments as much as possible. We also use a PHP to stabilize clients for psychoeducation, relapse prevention in the case of drug or alcohol dependence and abuse, and to work on self-care. The length of stay varies, but it's typically about 2 to 3 weeks. And on the team are a psychiatrist and psychologist, a MFT, which is a Master's of Family Therapy, a nurse, and an OT. Let's see. Did we talk about the goals? Well, the purpose. So we're going to be working on stabilizing behavioral health symptoms, so getting that person back on an even keel, providing education related to the illness and its management. Again, relapse prevention, which could be coping skills, stress management, things like that. And then the development of better self-care skills. Here's a typical schedule in a PHP. So as you can see, it goes from 9:30 to 4, and it includes individual appointments, a community meeting, several different group therapy sessions, lunch, which is provided, a CBT group, a stress management group, and then the client goes home at the end of the day. The role of the OT in the PHP is to set goals and develop skills, and then also to re-engage or develop the following types of skills: ADLs and IADLs, social and recreation skills, interpersonal skills, and again, symptom management. Next up is intensive outpatient programs. So we had partial hospitalization, which is PHP, and now IOP. This is a step down from the PHP. The person, again, lives at home, but treatment is for just about 3 hours a day, so a half day, Monday through Friday. The purpose of this setting is to, again, stabilize, reduce symptoms, improve social functioning, but notice that there's also the added aspect of transitioning back into the community and increasing life skills. Typically, a 5 to 8 week program, so it's longer than the PHP, and again, same folks on the treatment team. This is indicated when someone is a little bit more stable, but they still need some intensive care. And it's a step down. All right. The role of OT in an IOP is goal setting and skill development, and then re-engagement or the development of ADLs and IADLs, so similar to the prior program. Also social and recreation, so we're expanding out a little bit. Interpersonal skills, in other words, dealing with others, which is really important for being independent in the community. And again, symptom management. Notice we keep coming back to this idea of symptom management because, folks, medication needs change over time and their symptoms can ebb and flow. And so we really want to be on top of that so that they can maintain a stabilized state, and also so they are empowered and knowledgeable about how to deal with some different symptoms coming up, and can either get some assistance or can know how to regulate that themselves and have some strategies. And of course, if it's a medication change, that would need to be under the guidance of their psychiatrist. An example of this is, again, Mills Peninsula. They have both a PHP and an IOP, and they often mix clients from those two programs into the same groups. There's both individual assessment and group observation, so seeing how the person's skills are and then how they do interpersonally. And then a lot of group treatment. So there's task groups, movement, DBT, experiential therapies, expressive therapies, leisure skills, and life skills. So what it would look like is that it's partial to full day. It's 5 days a week, as we said. There's two patient tracks with 1 to 2 OT groups per day and 1 to 10 patients per group. So really varies. There's morning rounds prior to the groups, and again, it's for the purpose of reviewing new patients, seeing progress and updating on existing patients, and talking about concerns. And new patients are assessed by OT outside of this structure, and it can often take 1 to 2 days to complete once it's initiated. The groups, task groups are things like arts and crafts and other distraction type tools. Movement is another word for exercise. DBT, education and discussion. Experiential therapy are things like guided relaxation and progressive muscle relaxation. Expressive therapy is art with discussion, and then, as I said, leisure skills and life skills. The treatment sessions individually are held again as needed, with the case manager requesting, and they address issues that come up. Next up is community-based services. As you can see, we're going from most restrictive to least restrictive. So this is a less restrictive environment. There's a significant variety of services that the person might have. The goals are managing their illness within a community setting, developing more life skills, community integration, medication management, and coping. Frequency is 1 to 5 times per week, and diagnoses vary, but you don't need to be in acute need to access community-based services, and programs sometimes focus on a specific diagnosis or a specific age group. So for the purposes of our class, there may be a program that focuses, and we'll see some of them, specifically on youth or transitional aged youth. The length of stay really depends, varying on the program and its funding, and the team varies as well. The role of OT in community services are to assess initially and then collaborate with the client and with the team on a variety of settings, so school, work, social, family settings. The intervention focuses on community living and functioning, so being able to be out there and hold one's own. And services may be group, individual, and potentially involve the family system, especially if the individual is living with their family or dependent on their family in some way. An example of a community setting is OTTP, which is in San Francisco. It stands for Occupational Therapy Training Program. They work on goals, they work in various settings. They go with the client where they are needed, to school, home, park, job, etc. Various goals, as you can see: social interaction, coping, connection to community resources, exploration of interests, and in fact, employment. So I'm laughing a little bit because, we're often known for, do you get people jobs? No, we don't. But sometimes we do help people with employment and in the work world. The funding comes from grants from city, state, and federal programs, and there's a varied length of stay, anywhere from 3 months to 6 years, so it can be quite long term. The team consists of MFTs, MSWs, which is a Master of Social Work, a psychiatric nurse practitioner, OTs, and case managers. Another example of community-based services is El Camino Hospital, which is in Mountain View, California, a little ways north of San Jose, and they have a continuing care program. That's an adult program. They also have an adolescent program, which is the After-School Program Interventions and Resilience Education Program, or ASPIRE is its acronym. They offer addiction services, services for dual diagnoses, so that is drug or alcohol dependence along with another mental health diagnosis, and maternal outreach mood services. So for moms that need some extra help, either prenatally, perinatally, or those with children.